Indications or class 1 therapies are either calcium channel blockers, beta blockers, any AV node blocking drug. In our stepwise fashion that we went through, if they have tried non-pharmacological treatments, they've tried the Trendelenburg raising of the legs, they've tried the Valsalva techniques and it hasn't terminated, then they go to the next step. We're talking about a patient that presents acutely in the emergency department. The next step is that we give adenosine. If the adenosine did not terminate the arrhythmia, then they have the choice of either giving IV verapamil or IV beta blocker. Few points about giving IV calcium channel blocker or verapamil: that you have to ensure that you know the patient has a structurally normal heart, because it's a negative inotropic, and if you give it and they have structural heart disease, LV dysfunction below the 40%, you can cause them hypotension. If we're talking out of the acute setting and we're talking about ongoing symptoms that are recurring and repeating, then it is up to patient preference, really. If they are happy to have 1 or 2 episodes a year, and they can tolerate that, and they can go to the emergency room, or when etrapamil becomes available, they can do it intranasally, then that's fine. If they, on the other hand, want a complete solution, and catheter ablation has very, very high success rates, very low complication rates. If they want to take medicine for the rest of their life, they can do that. Antiarrhythmics, as such, are second line, 2A indications, because they do have a complication risk with time. They can become pro-arrhythmic, and they can, with many, many years, enhance atherosclerosis of the coronary arteries.
Thank you very much.
هذا محتاجين صوت.
All my friends, my colleagues and good friends, Dr. Yousef Darrat, cardiologist, vaccine taking United States. Yeah.
السلام عليكم.
السلام ورحمة الله.
أنا عرفت دكتور يوسف virtual online, and we came together because we are enthusiastic about electrophysiology in Africa. Dr. Yousef was very generous with his time to teach in the African Heart Association and to help us with his ideas. And وسبحان الله بعد عدة سنوات تلاقينا، يعني الحمد لله لقاء العلماء، الحمد لله لخدمة الطب والمرضى، والتقاء بمستوى الإلكتروفيسيولوجي في أفريقيا وفي ليبيا وفي مصر وفي السودان وفي جميع تحت بقى كينيا وتنزانيا. إن شاء الله بإذن الله يعني كله هيبقى إلكتروفيسيولوجي. فبشكرك دكتور يوسف. احنا تعرفنا من قبل كده برضو عشان نتقابل في ليبيا من عدة سنوات، لكن تقابلنا بيقول لك ايه، اللقا نصيب.
الحمد لله. الشرف لينا دكتورة، شكرا على حضورك، واحنا مبسوطين ان حضرتك موجودة معنا اليوم ان شاء الله.
انا اسعد والله.
وطبعا we're looking forward for your participation، وحضرتك عندك محاضرة ان شاء الله اللي جاية باذن الله. مشكورة جدا دكتورة. دكتور أسامة كان ديرنا لوج ان. باي طلعت خلاص. أنا نبي أسئلة وانتوا روحكم أسئلة.
ليه؟
المرة اللي فاتت ما سألوش، بس المرة هذه نبي أسئلة، عايزهم يسألوا أسئلة.
لا أنا هسألهم أنا.
طيب.
خلاص. حبايبي. على فكرة السؤال ما ينتقص من اللي بيسأل.
بالظبط يعني.
بعدين ما حدش يقول
وين
ده مش عارف يعني إيه ORT ولا سيركس موفمنت خالص. انت بتسال ان انت
نحركه من هنا
نفسك ومخلص مع نفسك، انت عايز
هذا يحرك.
ايوه طلب العلم فريضه على كل واحد فينا. انت هتقف قدام عيان انت مش عارف، لو قلت من حق العيان عليك انك تقول له طب بص انا هسال الدكتور يوسف او اسال الدكتور خالد او اسال الدكتور اسامه وهرجع لك. ممكن في عيانين مخهم صغنن كده يقول ايه ده كمان ما بيعرفش، راح يسال لي ناس ثانيه مش مهم، بس في 10 بقى ده 1 من 10، في 9 هيقولوا انا هستنى رد الدكتور لانه امين ومخلص معايا. انا بتحصل معايا لحد هذه اللحظه في العياده، ويمكن اسامه يبعت لي حاجه اقول له استنى يا اسامه، وابعت ليوسف وابعت هنا وابعت هنا وابعت هنا واشوف ايه الراي الصح وابلغ المريض. لا ينتقص من حقك شيء خالص. بس
طيب شكرا دكتوره. السلام عليكم ورحمه الله وبركاته. We'll talk about idiopathic VT. Okay, disclosures. This is my disclosure. الobjectives طبعا we'll talk about recognizing it. I chose idiopatic VT لأن sometimes I get calls من ليبيا على idiopatic VT, so I know it happens في ليبيا. Okay, yeah. سامحوني. Idiopatic VT sometimes I get ECGs, idiopatic VT, so fascicular VT, RV, very common, RVOT, PVCs of VT, idiopatic VT, we see it here in Libya موجودة. It's a very important topic that needs to be recognized. Sometimes it's difficult لأن ECG can be very tricky. بالنسبه للventricular tachycardia طبعا RVOT VT or PVCs it's kind of easier to recognize, like sometimes fascicular VT can be confusing. It could be narrower complex. It could be confused with SVT with aberrancy. So we'll talk about identifying role of medical therapy and the role of ablation. Okay, I'll present the case. This is a very interesting case that I did about maybe 2 months ago. تقريبا في شهر 5 ل 6 4 months ago. It's a 23-year-old, no previous history of syncope, palpitation, dizziness, no previous cardiac history. Like within the last 6 weeks, complaining of syncope, dizziness, palpitations, no previous cardiac history. Echo, he was referred from another cardiologist. The echocardiogram is completely normal. He was referred for possible AFib versus VT. It wasn't really clear. And he was started beta blocker. There's not much response. Patient was very, very symptomatic. So I'll show you the ECG and you tell me what you think, okay? Try to look at the ECG. I'll give you a few seconds. It's irregular, okay? Irregular. Wide QRS, left bundle. Yeah. شنو الديفرنشال دايجنوسيس؟ شو رايكم؟
Determined axis undetermined.
Yeah, the axis. Yeah.
Difficult to say whether left or right.
Almost normal axis. Yeah, AVL is normal. That's not almost normal axis. شو رايكم؟ But what could it be? What's the differential diagnosis? So how would you describe this? So irregular white complex. Everyone said that. Okay, irregular white complex. What's the differential diagnosis? So AFib with aberrancy. Yeah. So differential diagnosis could be atrial arrhythmia. يعني ممكن زي ما ورد الدكتورة نادية. It could be like underlying flutter with variable conduction, AFib with aberrancy. The differential diagnosis also consider ventricular tachycardia and a white complex. طبعا always when you have an ECG, if it's not clear, get another ECG if the patient's arrhythmia. Get a rhythm strip. I mean, print a rhythm strip. Look at it. The longer you look, the more you can see. Okay. Or the more you can find. This is the ECG, another ECG. You can see like P wave. Yeah, there's a P wave QRS وبعدين white complex similar to the other white complex وبعدين يعني خلاص أصبحت إن ال AFib is less likely صح؟ And it's very unlikely AFib will be for a few seconds. Very high likelihood that this could be VT. صح؟ Okay. لكن طبعا it's irregular. VT can be irregular. So this is an interesting ECG. لأن VT usually we know that VT is regular. لكن sometimes it could be if it's not re-entry. يعني the most common arrhythmia is re-entrant VT as a mechanism. Like could it be triggered activity? Could it be automatic, abnormal automaticity? يعني firing that comes and goes. Right. فالبيشنت دار له هولتر من الريفيرنج دكتور طبعا it was read as runs of ventricular tachycardia. He has like sinus rhythm وبعدين runs of VT. The longest was less than 30 seconds. يعني it was all kind of cold, non-sustained, multiple PVCs, very frequent. فطبعا workup, if you see such a patient طبعا you do the metabolic panel, electrolyte, CSH, echocardiography in Darrat, or echocardiography was normal. MRI is really important. I ordered an MRI لكن where I work they don't have an MRI machine. I have to send them somewhere else to another hospital. فاتأخر شوي الMRI, but the patient came back, he was very symptomatic. قال خلاص I can't take it anymore. We proceeded an EP study and ablation. PET scan or positive emission tomography important. If sarcoidosis, put sarcoidosis as one of the differential diagnoses. يعني هنا لما نشوف حاجة زي كده sarcoidosis, could it be sarcoidosis or not? طبعا بتشوف chest X-ray, mediastinal widening. Sometimes there's isolated cardiac sarcoidosis. That's why I threw it there. Okay. Next step, medical therapy versus ablation. فطبعا احنا بدينا beta blocker لكن there's no response. Patient is very symptomatic, very frequent. We decided to do an EP study and ablation. Okay. طبعا when we take someone to the EP lab, we want to think where it's coming from. انتم شفتوا it's left bundle. So when we say it, Right side. Okay, left versus right, so it's most likely yeah, right side. It is طبعا الاكسس كان موجود في inferior. It's positive inferior leads. هيكون لا inferior معناها جاي من anterior wall. لا الاكسس inferior. نرجعوا لها. Positive inferior leads. Yeah. شوفها. Positive inferior leads. فgoing towards. ايه جاي من anterior wall. ايوه. anterior wall يعني right ventricle anterior wall باي. والترانزيشن حتى transition وين؟ is it basal أو apical؟ كان V5 it's late معناها towards the apex معناها ممكن الميد right ventricle anterior. وسبتال versus free wall this is likely free wall. شنو السبب؟ لأن حتى عندك notching it's wider. حتى عندك notching that's one of the signs notching في inferior leads. Okay. وفعلا هذا اللي صار يعني when we mapped it we found that it's coming from هذا طبعا just to remind you guys ان ال V1 is very important. That's one of the first thing I look at. لأن ال V1 is rightward يعني it's right here on this side. ف anything in the left ventricle going towards V1 is going to be positive. It's going to be positive. لكن لو حاجة في right ventricle like this case left bundle حتكون negative V1. Okay. وقلنا superior inferior أي حاجة if it's positive inferior leads معناها anterior. If it's negative معناها posterior لأنها جاية away from. okay. وانتم عرفت تكلمنا على هذا تكلمنا على السبتال طبعا الكيو ار اس if it's more than 140 it predicts more kind of free wall or lateral wall. Less than 140 could be septal. Okay. Patient diurnal ablation. I have slides if I want to show you about cartoon mapping or 3D mapping. Like I don't want to really present it. That's not the main topic. The main topic احنا نتكلم على idiopathic VT. No PVCs. It's successful. When I did the ablation, I mapped it. It's فعلا anterior side. I was thinking it's the papillary muscle. I ablated there. لكن exit side changed towards the septum. I also ablated on the moderator band. يعني could it be from the